So we'll approach part 2 of our neonatal review questions. Question 11 gives us a 3-month-old girl who presents to the ED with her parents complaining of irritability, inconsolable crying, and blood in the diaper. She was born at 35 weeks and 3 days of gestation and spent 4 days in the NICU for respiratory distress, which resolved. She'd been well until now. There have been 2 episodes of non-bilious vomiting. Physical exam is remarkable for abdominal distension and tenderness. Bowel sounds are reduced. Stat labs reveal white blood cell count of 16,000, platelets of 110,000. Abdominal x-ray is performed. I'll show you that next. Which of the following is not part of the initial management of this patient? So here's a look at that abdominal x-ray. You can go ahead and pause it here if you want to get a better look. You can turn it to full screen to look at it even bigger. So this is the abdominal x-ray. And the question is asking which of the following is not part of the initial management? Is it NPO, B, NG decompression, C, IV piperacillin-tazobactam, D, immediate surgery, or E, serial x-rays, abdominal x-rays? All right. So the answer to this is D, immediate surgery. So this is a child with a history of preterm that is presenting with abdominal pain, abdominal irritability, and more concerningly, blood in the diaper. Now, a baby who's crying is not uncommon, but typically when a baby's crying, there's something in particular that the baby wants. So the baby wants to be fed, the baby's afraid, the baby wants to be held. When it's inconsolable crying, typically that means that the baby's uncomfortable or there's some kind of pain. And indeed, that's what we note on physical exam, that there's abdominal distension and tenderness. Furthermore, the fact that there's blood in the diaper indicates that there's some kind of GI process going on. Now, when we look at our abdominal x-ray, we see a very distinct sign, and that is pneumatosis intestinalis, and that's air in between the layers of the intestine. And that can only mean one thing. Well, it can mean other things, but typically this, when you see this in an infant that presents like this is necrotizing enterocolitis, and this is only really seen in preterm infants, and it can happen even if they're well after discharge, but it's preterm infants, that's the population you'll see this in. The labs are indicative of an inflammatory process going on. The white blood cell count is elevated. You can also get a thrombocytopenia, which we do have in this case. Roughly for infants this age, the platelet count, the normal platelet count, is anywhere between 170,000 and 410,000 roughly. So the way we manage necrotizing enterocolitis is conservative at first. We don't want to go into surgery right away if we don't have to. One of the more ominous signs that is going to push us towards surgery is perforation. And we need to be very, very, very careful that we're monitoring this baby to see if there's any perforation present. So let's go over this. So necrotizing enterocolitis has an unclear etiology, but likely it's due to a hypoxic insult, and that hypoxia causes intestinal sloughing. The bacteria can then invade that area of the intestine that's sloughed off. There's then inflammation, gangrene, and perforation. And like I said, this almost always is in the premature infant, so that's important in the history. The symptoms are a preemie baby who comes in with abdominal distension, belly pain, and bloody stool. Other symptoms can include intolerance to feeds, vomiting, diarrhea, decreased bowel sounds, and erythema over the abdomen. That's a really bad sign. That's going to be one of the signs that send the baby in for immediate surgery. And then shock, which this baby doesn't have. Initial labs will be useful to start out with. You'll want to get a metabolic profile and a CBC. Your CBC can show thrombocytopenia. It can show an abnormal white count, but note that you don't always see an elevated white count in all babies when they are going through some kind of septic process. It could be a low white count. Your metabolic profile can show a low sodium. It can also show a metabolic acidosis. Blood gases will be useful as well in the further workup of this patient. For diagnosis, the best initial diagnostic step is an abdominal x-ray, which we got. In necrotizing enterocolitis, this will typically show a dilated bowel with edematous walls, and most ominously, intramural air, which we saw here, and that's called pneumatosis intestinalis. And for the most part, when you have a baby that is premature, was premature, and gives you this presentation, pneumatosis intestinalis is practically pathognomonic for necrotizing enterocolitis. At that point, you should be observant for signs of bowel perforation, because perforation is an absolute indication for emergent surgery. Another indication for emergent surgery would be this erythema over the abdomen. Now, when you're getting your x-rays, it's very important that you order both AP x-rays, because that's going to show you your dilated loops of bowel. It's also going to show you the pneumatosis intestinalis, but you also want to get a left lateral decubitus x-ray. And the reason is because when you have early perforation, you may only have a little bit of air in the abdominal cavity, and that's the best x-ray to see perforation, abdominal perforation, to see mediastinal air. And that goes for anybody. So you're looking right above where sort of the liver and the intestines kind of meet in that area. And that region will fill with air very quickly in the left lateral decubitus x-ray very early on in perforation. So the management is going to be an immediate surgical consult. You're going to want them aboard right away. And then you're going to have these children as NPO. The reason you want them as NPO is you don't want to be putting any more food or anything else into the intestines. You'll also decompress everything else that's down there. Again, sort of for the same reason. You don't want any more food product going down into the diseased intestine. You'll supply supplemental oxygen and also closely monitor their saturation. Since you're not feeding them, you'll give them IV fluids and total parenteral nutrition. You also want to give them prophylactic broad-spectrum antibiotics. Since this is a bacterial inflammatory process, you can give, it needs to be just wide spectrum. So ampicillin and gentamicin would be good. Piperacillin tazobactam is good. Make sure you're covering those anaerobes. Also, you're going to be repeating the abdominal x-rays, keeping an eye out for perforation, and then you'll also want to get blood gases, and you can insert an umbilical catheter for that. You're going to do immediate surgery if there's any evidence of perforation on x-ray, if there's a fixed dilated loop of small bowel over the course of several hours, if there's abdominal cellulitis, or if there's deterioration in the patient's status despite maximal medical support. Whether or not you do surgery, you don't resume PO feeds until the disease resolves symptomatically and objectively. Okay, question 12 gives us a G3P2 mother who delivers an 8-pound, 4-ounce baby via spontaneous vaginal delivery. APGAR scores are 8 and 9 at 1 and 5 minutes. On physical examination, you note ambiguous genitalia. Examination is otherwise normal. Labs and karyotype are ordered and reveal a 46XX karyotype. Sodium is 130, potassium is 6.2, chloride is 102, bicarb is 25, BUN is 15, creatinine is 0.6, and glucose is 95. Which of the following is the best next diagnostic step? Is it A, fluid replacement, B, 17-alpha-hydroxyprogesterone level, C, referral to peds gynecology for surgical correction, D, hydrocortisone and fludrocortisone, or E, fludrocortisone? All right, and the answer to this one is B, 17-alpha-hydroxyprogesterone level. So you have a child here with ambiguous genitalia. This baby is healthy otherwise, so we're going to, of course, order labs, and karyotype is important whenever you have a baby with ambiguous genitalia. You want to know what their genotypic gender is, what their sex is, because that will tell you whether or not this is a penis that hasn't developed appropriately or whether this is a virilized baby girl. And indeed, it winds up being the latter, a virilized baby girl. And that happens very commonly in congenital adrenal hyperplasia. And when we look at the CMP or the BMP, we see that there is a low sodium, elevated potassium, and that is consistent with congenital adrenal hyperplasia. Remember, in congenital adrenal hyperplasia, we typically have a lack or an absence of 21-hydroxylase. And when you don't have 21-hydroxylase, you can't produce cortisol and aldosterone. And aldosterone is responsible for the preservation, the reuptake of sodium, and the excretion of potassium in exchange. So when you have a low aldosterone, your sodium is going to be low and your potassium is going to be high. So that's consistent with congenital adrenal hyperplasia. Now remember how that whole axis works. Your body senses that there's low aldosterone, which there is, and low cortisol, because you don't have the enzyme. But when your body senses that, it's going to respond by, and also because you have low sodium, it's going to respond by secreting more ACTH. But that doesn't resolve the enzymatic block. And so all of that precursor is going to be shunted off to produce sex hormones. And so because of that, you have excess androgen, and that's what's caused the virilization and this ambiguous genitalia in this baby girl. Now, the 17-alpha-hydroxyprogesterone level is the best test to get because this is a precursor of 21-hydroxylase. And so this particular hormone, this chemical, is going to be elevated, very elevated. Now, these other things are things that you can do. However, this baby does not need fluid replacement at this time. The baby is otherwise normal. A referral to peds gynecology for surgical correction absolutely is going to be needed at some point, but we need to make a diagnosis first. Hydrocortisone and fludrocortisone is going to be the ultimate treatment. However, we need to make a diagnosis first. You wouldn't give fludrocortisone alone. You need to replace both the mineralocorticoids via fludrocortisone and the glucocorticoids via hydrocortisone. So congenital adrenal hyperplasia has sex-specific presentations. Typically, it's very easy to diagnose early on in the female as you get an ambiguous genitalia that causes clitoromegaly, fusion of the labia majora, and abnormal urethral path, sort of turning in the external genitalia into something that looks more like a penis. In a male, they tend to appear normal at birth because you can't really virilize a penis. It's already virilized. However, they can have increased scrotal pigmentation. Now, in both sexes, there will be salt wasting and dehydration to some degree due to low aldosterone, and that can appear during the first month of life. It can appear right away. It really just depends on how severe it is. Low sodium symptomatically is going to result in irritability, tachycardia, loose stools, vomiting, poor feeding, shock, and coma. For diagnosis, it can be diagnosed as part of routine newborn screening. Most newborn screening examinations include a alpha-hydroxyprogesterone. However, when it's really early on, because it takes like about 3-5 weeks for a newborn screening test to get back, if it's early on, you need to know how to diagnose this, and that's going to be via the 17-alpha-hydroxyprogesterone test. And so you'll want to diagnose this right away. You don't want to wait for the newborn screening test to get back. So if congenital adrenal hyperplasia is suspected, you should get electrolytes. That's going to tend to demonstrate a low sodium and high potassium. Even if it's at the lower level and higher level of normal, upper limit of normal, respectively, you should go ahead and get a 17-alpha-hydroxyprogesterone because the severity of the salt wasting can vary. And so if this is a really mild case, you may not have a quote-unquote low sodium. It might just be lower limit of normal. So a 17-alpha-hydroxyprogesterone is very specific for 21-hydroxylase deficiency, and that will really establish your diagnosis. The treatment is going to be fluid resuscitation and close monitoring of electrolytes. Of course, you can do that before you do the test, the 17-alpha-hydroxyprogesterone test. But this particular question said which of the following is the best next step in diagnosis. So you need to diagnose congenital adrenal hyperplasia, and certainly if the baby appears well and the electrolytes are stable, you don't need to pump the baby with anything right away. It's not an emergency. Glucocorticoids and mineralocorticoids are going to be necessary to replace these corticoids that the baby is lacking because of the enzyme deficiency. So you'll give glucocorticoids, which is typically hydrocortisone, and that's titrated to normalize the 17-alpha-hydroxyprogesterone. What's happening here is that we're giving the baby the stuff that they lack, and so we turn off that positive feedback loop. So since there's now glucocorticoids and mineralocorticoids, that should lower the ACTH level to where the 17-alpha-hydroxyprogesterone will go down. And so we titrate it to normalize the 17-alpha-hydroxyprogesterone. Mineralocorticoids, typically in the form of fludrocortisone, are administered, and we monitor the blood pressure and the renin levels. Remember that renin is the response to low sodium, low blood pressure, and that also ups your ACTH. We'll also consult pediatric endocrinology. Typically, we'll refer these children off to them, and then pediatric urology and or gynecology should be consulted for all girls, as they may need corrective surgery. So this is an example of a viralized, somewhat viralized external genitalia of a baby girl. This is the clitoris. This is obviously clitoromegaly here. And then you can see some fusion of the labia majora. This is an example of a boy with congenital adrenal hyperplasia. You can definitely note the increased pigmentation on the scrotum as well as the glands. This is corrective surgery. So you can see that this external genitalia looks just like a penis, but it's not. This is significant clitoromegaly. And then this is the after surgery. All right, question 13. A 5-month-old baby presents with his mother complaining of frequent non-bilious vomiting after feeding. Mother is very concerned. This is her first child, and she doesn't know what she's doing wrong. She denies any problems feeding and says he is immediately hungry after vomiting. On physical examination, you note mildly sunken fontanelles. Vitals are stable. Labs reflect a hypokalemic, hypochloremic metabolic acidosis. Which of the following interventions will most likely benefit this patient? A. Smaller, more frequent feeds. B. Pyloromyotomy. C. Nissen fundoplication. D. Labs procedure. Or E. Conservative treatment, observation for 48 hours. All right, so the answer to this one is B. Pyloromyotomy. So here you have a firstborn baby boy, and the baby is having non-bilious vomiting, particularly after feeding. Now, the thing with vomiting is we always want to know, is this obstructive or is this not obstructive? And obstructive vomiting can happen, obstructive vomiting can be bilious or non-bilious, more often bilious, I should say. However, well, I should say this could be, anyhow, let me go on here. So we want to know if it's obstructive in the intestine or not obstructive in the intestine. We'll put it that way. And that can be non-bilious or bilious. But there are other ways that you can get vomiting. So in this case, you have a baby that is hungry right after vomiting. And what that tells you is that the obstruction is likely in the stomach. So that and the fact that it's non-bilious. So when you have an obstruction in the jejunum, for instance, that's going to be bilious vomiting because you're vomiting up stuff that's in the duodenum. The bile gets into the stomach and then that's thrown up. On the other hand, when you have an obstruction in the stomach, like we have here, this is hypertrophic pyloric stenosis, the baby's going to be hungry right afterwards because the baby's not getting any nutrients at all. The food's getting into the stomach, it's not passing through the pylorus into the duodenum, and so the baby's not getting any nutrients. The baby's just throwing up. And that's reflected in the fact that there's a hypokalemic, hypochloremic metabolic alkalosis. The potassium, the chloride, hydrogen ions are all being wasted through the vomit, and that's causing the alkalosis. So now we know we have hypertrophic pyloric stenosis. What is this? This is hypertrophy of the muscular layer of the pylorus, which results in a gastric outlet syndrome. Typically, this presents between 2 weeks and 2 months of life, but it can be much later. It has a male preponderance of 4 to 1, and it's also more commonly seen in firstborns, and there's also an increased incidence if a parent has a history of hypertrophic pyloric stenosis. The symptoms are projectile, non-bilious vomiting. This is always non-bilious, so if the vomiting is bilious, it's not hypertrophic pyloric stenosis. And then this is followed by a desire to feed because the baby's still hungry. Baby's not getting nutrients into the intestine. You can't absorb glucose or fats or proteins in the stomach. You can only do that in the intestines. And so if food's not getting into the intestines, the baby's going to be hungry. There'll be symptoms consistent with dehydration, both because the baby can't get as much nutrients and water into the intestine, and also because the baby's vomiting. Parent may describe constipation. That's generally because they're not having any stooly diapers. That's because they're not getting food into the intestine. Labs, of course, will be consistent with a hypokalemic, hypochloremic metabolic alkalosis for reasons described. In some cases, you may be able to palpate an olive-like nodular mass over the epigastric right upper quadrant area. If you can palpate that, that's very telling of HPS, but regardless, you should get a sonogram. For diagnosis, it can be highly suspected clinically, but abdominal sonography and/or upper GI contrast series are usually performed to confirm diagnosis. So the management for HPS is going to be to get surgery on board right away. Best initial step is, of course, with any baby that's dehydrated, sunken fontanelles, history of vomiting, it's going to be to replenish their fluids as well as to correct any electrolyte or metabolic abnormalities. Typically, you'll do this by giving a bolus and then also potassium since they tend to be hypokalemic. You'll also want to put in a Foley catheter, and the reason for that is the best way to know that a baby is being hydrated is to measure their urinary output. And that should be roughly between 0.5 to 1 mils per kg per hour, and that will ensure adequate hydration. Once the baby is stable, you can do surgical correction. That's a pyloromyotomy. All you're doing is making an incision of the serosa over the pylorus that divides the antrum. You should not enter the duodenum or the stomach. Following surgery, liquids can begin at 4 to 6 hours post-op, and you can do full feeds at 24 hours barring any complications. Post-op vomiting is very common. As a matter of fact, it's kind of the norm, and it happens in between 50 and 80% of the patients that get this surgery. It's very self-limiting. Complications that can come out of this are apnea, so all patients post-op should be on an apnea monitor, as well as duodenal perforation during surgery. And if that happens, it's not a huge deal, but it should be repaired, and then IV antibiotics and NG decompression should start after the operation. Question 14. A 2-day-old term baby girl is noted to be jaundiced in the newborn nursery. She's otherwise visibly normal. On labs, the total serum bilirubin is 8.9 milligrams per deciliter. Conjugated bilirubin is 1 milligram per deciliter. Direct Coombs test is negative. Peripheral blood smear is normal. Which of the following is the most likely etiology in this patient? A. Biliary atresia. B. Gilbert syndrome. C. Rh incompatibility. D. Physiologic jaundice. Or E. Crigler-Najjar syndrome type 2. Okay, and the answer to this one is physiologic jaundice. So you should know what physiologic jaundice is. It's not only important to know what physiologic jaundice is because so many babies have it, but it's also important to know what physiologic jaundice is so that you know when it's not physiologic jaundice. So what is physiologic jaundice? Physiologic jaundice is never visible on the first day of life. So if a baby is yellow and they were born within 24 hours ago, this is a pathologic jaundice, regardless of what the levels are. With physiologic jaundice, the total serum bilirubin can rise up to 5 milligrams per deciliter per day until day 3 to 5. But if it's rising faster than that, then you should consider this pathologic. Conjugated bilirubin will never pass 2 milligrams per deciliter or 20% of the total serum bilirubin, whichever is lower. So for instance, if a baby has a total serum bilirubin of 7, then their conjugated bilirubin should not be more than 1.4. That's 20%. If it's more than 1.4, if they have a total serum bilirubin of 7 and a conjugated bilirubin of 1.9, even though that's below 2, you should still consider that a conjugated hyperbilirubinemia. The total serum bilirubin will peak around day 3 to 5, maybe a little bit later in preterm babies. And then the visible jaundice should resolve by 1 week of age in a full-term baby and 2 weeks of age in a preterm infant. And I will add there are these nomograms that you can use where you measure the total serum bilirubin to the age, and it gives you, based on the baby, whether they're preterm, term, whether they're sick, etc., whether or not you should do a UV phototherapy or an exchange transfusion. You'll be given those nomograms on the test if they want you to use it. You should know how to use it because it will tell you if you need to use UV phototherapy or exchange transfusion. Question 15 gives us a 6-week-old baby boy who's admitted and observed to be engaging in swimming-like motions and lip smacking. This has been going on for the past 5 minutes. Vitals are stable. Rectal temperature is 98.5 Fahrenheit. Heel stick glucose is 95 milligrams per deciliter. Which of the following is the best initial step in management? A. Pyridoxine, B. Phenobarbital, C. Fosphenytoin, D. Lorazepam, or E. Cranial sonography. All right, and the answer to this one is B, phenobarbital. Now, if you work in adult medicine like I do, you would be surprised by this if you weren't aware, because the first step we do in adult medicine, of course you get the glucose level and everything if you can, but the first medication that you would give in an adult seizure would be a benzodiazepine, like lorazepam. Not so in children. In children, first you're going to go to a barbiturate, and that would be something like phenobarbital. That would be the first thing you would give. The second thing you would give, if that fails, is a benzodiazepine or an anti-epileptic drug like fosphenytoin. Now, cranial sonography is good if you have a newborn baby with a seizure, particularly preterm, because you're looking for periventricular or interventricular hemorrhage. That's not indicated in a 6-week-old baby boy. Pyridoxine is something that you can give if all else fails. However, you can give it right away. It really is a call of the pediatrician. We'll look at the schematic here. So just looking at neonatal seizures, important to remember manifestations of seizures in neonates can be extremely subtle and are often missed. Also, significant seizures can occur in the absence of visible signs. So the signs that we typically see in a neonate that indicate seizures include such subtle things like ocular deviation, eyelid fluttering, these sort of repetitive motions like bicycling motions or swimming-like motions of the arms, which can look somewhat spontaneous. Lip smacking, sucking, or other oral tics, and then more concerningly, apneic episodes. Neonates rarely have tonic-clonic seizures. The brain of the neonate is full of inhibitory neurons, and so because of that, grand mal seizures just are not something that we see typically in little babies. Most neonatal seizures will occur between 12 and 48 hours of life, and that is associated with ischemia or hemorrhage most of the time. That would be things like periventricular, interventricular hemorrhage, where you'd want to get that cranial sonography, but it could be other things too. Neonatal seizures that happen later on, usually after discharge, are more likely to be infectious or metabolic in origin. Your workup for a neonatal seizure is going to be to get a metabolic panel, including calcium and magnesium levels. You want to get torch titers, especially in the older babies like this baby, because congenital infections are a common cause of neonatal seizure. You also can get serum amino acids in the urine for organic acids, looking for defects of metabolism. Cranial sonography can be done, which may be followed by MRI. Really just depends on the age of the baby. That's more important, I would say, in younger, in neonates, brand new babies, 1-2 days old, than it would be in a 6-week-old or a 6-month-old. Lumbar puncture can be done as long as there's no contraindications. If there is, you should get a CT first. But xanthochromia, that would suggest a subarachnoid hemorrhage. Glucose in the lumbar fluid would suggest bacterial, if it's low, would suggest bacterial meningitis. And then you can also get an HSV PCR, which would, if it's positive, would indicate viral meningoencephalitis. And I may have misstated that. Lumbar puncture you shouldn't get if there's contraindications, but if there's relative contraindications, you should get imaging first. Another thing that's going to be important after you've done treating the baby is to get a 20-lead EEG on video. That will help you correlate any signs with spike wave discharges that you might see in seizures, and that can help direct your treatment. Of course, you're going to be doing that in consort with a neurologist. And then echocardiogram can be useful because a lot of these neonatal seizures, if they're associated with syndromes, they can also be associated with congenital heart defects. So please note, I mentioned this earlier, but it's worth noting again, the USMLE will try to trip you up with this. While the first line for treatment in adult and most pediatric seizures, older children, is benzodiazepines. When you're dealing with newborns, you're going to first give phenobarbital. So management of a seizure, when a baby's having a seizure, you want to ensure adequate ventilation and perfusion, monitor the pulse oxygenation, make sure that you're keeping an eye on their blood pressure. Immediately, you want to check their glucose levels and get labs to look at their electrolyte levels because those things can be fixed. If their glucose is low, you can correct that with an infusion of D10 water, 2 mL per kg, and then you can drip that at 6 mL per kg per minute. Also correct any electrolyte abnormalities if they're present. The first line treatment, symptomatic treatment for the seizure, is IV phenobarbital, 20 mL per kg. That will be your initial bolus. After that, if it's not working, you can continue giving phenobarbital in 5 mL per kg increments up to a total of 40 mL per kg. So you can give 4 additional dosages of 5 mL per kg increments. You can give those increments, so 4 more increments up to 40 mL per kg total. The second line treatment is fosphenytoin or lorazepam. Intractable seizures should be treated with IV or IM pyridoxine. Pyridoxine deficiency can cause seizures. Now when I put this down here, it means that pyridoxine deficiency is a less common cause of seizure than other things. But if you suspect a pyridoxine deficiency, or you could theoretically do this along with your first line treatment, but you should know that the very first way you're going to approach seizures is by correcting any abnormalities, giving phenobarbital, then possibly giving fosphenytoin or lorazepam. And pyridoxine is another way that you can treat it because a pyridoxine deficiency can cause seizures. And indeed, if they're intractable, pyridoxine deficiency can be what's behind it. But you can certainly give pyridoxine. I mean, I'm not a pediatrician, but it would just make sense to me, considering pyridoxine is really, can't really get a toxic effect with, unless you're just, megadosing the kid up. But just by giving a little bit of pyridoxine, the amount that they would give during seizures, there'd be no reason why you couldn't give this sooner. You don't need to wait for the kid to be in status epilepticus to give pyridoxine. And then consult neonatology and pediatric neurology as appropriate.